I would like to introduce our next speaker. Dr. Mary Zanarini is a professor of psychology at the Harvard Medical School, and she's director of the Laboratory for the Study of Adult Development at McLean Hospital. She's one of the most prominent leaders in the study of borderline personality disorder, pioneering many areas of research, including but not limited to the origins or etiology of the disorder, assessment, longitudinal course, and pharmacological treatments. She's also spent time studying things related to our topics of obesity, and that's what we'll be hearing about. It's a true honor to have her join our conference and educate us about these topics. Please welcome Dr. Mary Zanarini. Okay, and there is a watch over here, and I will flash you a time. Do you have it? Oh, you? I thought you had it. Oh, it's over here. Is it on?
Good morning. My topic today, as Seth mentioned, is obesity and obesity-related illnesses in patients with borderline personality disorder. I'm going to talk today primarily about the study that I've headed for the last 18 years, the McLean Study of Adult Development, or MSAD. This was the first NIMH-funded prospective study of the longitudinal course of BPD. It began with 362 McLean inpatients assessed at baseline, and now completed are 5 waves of blind follow-up, 2, 4, 6, 8, and 10-year data. Our 12 and 14-year waves are 99% complete, and there are a few of you who haven't been interviewed yet, and you know who you are. And there's a 16-year wave that's 2/3 complete, and our 18-year wave will begin in July of this year. Now, our subjects were 290 patients meeting DIB-R, and I'll explain what that is, and DSM-3R criteria for BPD, and 72 Axis 2 comparison subjects meeting DSM-3R criteria for another personality disorder, but neither study criteria set for BPD. I should say that the Axis 2 comparison subjects looked sort of borderline when they were hospitalized. These were all young adults. They were angry, they had stormy relationships, they were suicidal. That's how people get into the hospital. And to talk about the DIB-R is the revised diagnostic interview for borderlines. The original DIB was developed by John Gunderson at McLean in the 1970s. When I came along as a graduate student, he graciously and somewhat mysteriously allowed me to revise it willy-nilly as I thought best. And what I did was I came up with an instrument that has 4 sectors of psychopathology: dysphoric affect, disturbed cognition, impulsive behaviors, and troubled relationships. And this is both a dimensional measure and a categorical measure. Now, the DIB-R definition of borderline personality disorder, it requires symptoms in each of these 4 domains of borderline psychopathology at the same time. So it deals with some of the problems that Carlos highlighted of heterogeneity, and it results in a somewhat smaller and more homogeneous group of patients than the DSM criteria. One borderline patient looks very similar to the next because of this diagnostic system. Now, subject retention over time, still at 10-year, and it's not that different actually as we've moved out. 92% of surviving patients with BPD or borderline personality disorder are still participating, as are 85% of surviving Axis 2 comparison subjects still participating. And we owe this in large measure to the fact that these patients are very affiliative. And once they gave their commitment to the study, they've stuck to it. I also want to thank my research assistants who've had phenomenal social skills in handling people who initially were intriguing and now are simply delightful and really a member of our larger family. Now, time to symptomatic remission. Remission was defined in our study as no longer meeting either criteria set for BPD, DIB-R, and DSM-3R for 2 years. And this wasn't a migration down one symptom, because the DIBR studies 22 areas of psychopathology. The important thing to remember is that after 10 years of follow-up, and these are cumulative percents, they're building over time, 93% of these patients who are very disturbed inpatients have achieved a remission. Looking at the concept of time to sustain symptomatic remission, and this is an article that's recently come out in the American Journal of Psychiatry, EPUB, ahead of print. You can go to the website and download it for free. 86% of the people have had a sustained remission, and that's 4 years of no longer meeting either criteria set for BPD. So this is very good news. When we started out, people suspected that this was a chronic disorder. That did not seem to be clinically true. And after 10 years, if 93% of people have remitted for at least 2 years and 86% for 4 years, that's looking good. Now, time to symptomatic recurrence, that's stepping back from a 2-year remission. That's 31%. That's still a pretty low percent compared to what you would see with major depression. In major depression, you see a progression much more rapidly toward remission, but recurrence is much more likely to occur. In Marty Keller's groundbreaking work at Brown, what he's found is that almost 100% of people who have one episode of depression will have another over time. Now, these rates may climb over time, but we will be studying that and we'll be able to report that. Time to the loss of sustained remission, here you can see it's only 15%. So if you remitted for 4 years, your chances of having a recurrence are reduced by a factor of 2 or cut in half. Completed suicide, 4.1%, or 12 of these 290 patients, have committed suicide over the first 10 years of the study. Everyone expected from the results of the famous follow-back studies that this rate would be 9 to 10%. 4% is 4% too many, but it obviously is less than half of what was expected. And we've been able to track, due to the internet and various things being online, even the people who are no longer in the study, we know that if they're alive or not. And so this is of everyone. This is really good news. These patients have high rates of suicide attempts, but relatively low rates of suicidal completion. And I think that should give us some comfort in treating them. That is, every attempt is not that dangerous, although all attempts are unfortunate. Now, let's talk about broadly defined good psychosocial functioning. 78% of patients with BPD in our study attain or maintain, because some had it at baseline, broadly defined good psychosocial functioning over the course of 10 years of prospective follow-up. And we define this goal in a common sense way as having at least one emotionally sustaining relationship with a friend or romantic partner, not a relative, and both a good vocational performance and a sustained vocational history. You worked well, and you did it consistently over time. But you can see the percent drops down when we have narrowly defined good psychosocial functioning. And the interpersonal part was exactly the same, one emotionally sustaining relationship with a friend or romantic partner. But what was different here was you not only had to continue to have, or in this definition you had, a good vocational performance, you worked well, a sustained vocational history, you did it consistently, but this had to be full-time work or going to school. Now, the stability of good psychosocial functioning over time, broadly defined good psychosocial functioning is more stable than narrowly defined good psychosocial functioning. Now, why is that? Why it is that almost all failures to attain or actual losses of narrowly defined good psychosocial functioning were due to problems in the vocational and not the social realm. The vast majority of these patients have relationships that they find sustaining, but you'll see in a little bit that the problem is working full-time, which is, it's hard for us to maintain, but it is a logical definition of good psychosocial functioning, as Freud said, to love and to work. And what are the clinical implications of the psychosocial functioning findings? I've suggested that a rehabilitation model might be useful for those who cannot work or go to school full-time in an effective and consistent manner. Basically, we have now 5 forms of comprehensive treatment for BPD. And the problem really is that all of these treatments are aimed at what I call the acute symptoms of BPD. Submutilation, suicidality, none of them are aimed at what I call the temperamental symptoms of BPD, the more chronic problems, being dependent, fears of abandonment, aloneness. These treatments also are not typically aimed at vocational functioning. And what I'd suggest is that clinicians can do this kind of work themselves, or they can enlist the help of others. But no matter what insights your patient is gaining, no matter what your patient is gaining in terms of symptomatic reduction, if they're not able to function in the real world and support themselves, that's unfortunate for them, and it's unfortunate for society. And I've never known a patient who was put on disability because they were under so much stress around working that was ultimately that grateful for it in the end. Work, as I often think about it, is day treatment for the rest of us. And I think it's really a very useful modality. Now, we have this concept in this new American Journal article called Recovery from BPD. And we define recovery as having a concurrent remission from BPD and at the same time narrowly define good psychosocial functioning. So a massive reduction in symptoms, some type of social life, and the ability to work full-time in a competent and sustained manner. And as you can see, only 50% of our patients attain this goal. So it's a much harder goal to attain than remission. But it's a more realistic marker for all of us as clinicians, because this is what we want our patients. We want them not only to have fewer symptoms, but we want them to have a life. In fact, that is jokingly referred to as my form of treatment at McLean, Get a Life. People will say to me, I want this, I want that, I can't date, I've been abused, and I'll say, get a life. And basically, surprisingly, it's taken pretty well. Now, time to loss of recovery from BPD, as you can see, after 8 years after first recovery, about a third of people have lost this. And this is not surprising. And again, it's complicated, but work always plays a big role in this. And we have a big role in this too. We can see life as something that you struggle to attain the best life possible, or when there's an impediment, we've moved back with the patient and say, why don't you have a timeout? But unfortunately, sometimes disability becomes not a timeout, but a lifestyle. And no one is really, in the end, in my experience, that grateful for that lifestyle. Now, psychiatric treatment, just to let you know who these people are. There's a fantasy that McLean is full of wealthy patients lolling around in luxurious settings. We've really perfected shabby chic. The emphasis is on the shabby. And as this study began 18 years ago, our average length of stay plummeted in the first 2 months of the study from 60 days to 6 days. And it stayed around there. And half of our patients are people with public insurance, Medicare or Medicaid. Most of these people are treated in the community in psychotherapy by psychologists or social workers. And over 90% were in treatment at the moment they were hospitalized. And interestingly enough, 70% have remained or have gone back into individual therapy and pharmacotherapy or are on these things during all 5 follow-up periods. Just to locate this sample a little bit better, 79% of our sample of borderline patients had prior hospitalizations when they were first entered the study, their index admission, but in terms of a 10-year follow-up, only 29% had been hospitalized at all. So hospitalization tends to decrease dramatically, where psychotherapy and medications tend to proceed over time. Just one more slide before I get into the weight issues. In this sample, which I don't think is that unusual, there's a lot of aggressive polypharmacy, and most of these people are treated by psychiatrists in the community and increasingly by their PCPs. And they tend to, over 30% get 3 or more medications at any one time. Over 20% get 4 or more medications, and over 10% get 5 or more medications. And echoing what Carlos said, basically, these medications, it's never been clear to me, and I've done quite a few psychopharm trials, what this is really about. And I think what it may be about is that people are prescribing one medication for each symptom cluster of BPD and throwing in an extra one as well. These are meant to be helpful. I've never known, and there is no way of knowing, is this helpful and is this life-sustaining, and is this one of the reasons why people have a relatively low suicide rate in this study, or is this more destructive, or both? But let's look at weight issues. At baseline and 10-year follow-up, you can see that people being underweight dropped from 12% to 3%. Normal weight dropped from 52% to 41%. Being overweight, a little bit of an upward movement from about 20% to 23%, but being obese doubled from 16% to 33%. So we see there's less of a problem with restriction and more of a problem with gaining a lot of weight. Now, the prevalence of obesity over time, let's look at BPD versus OPD. And remember that these were all young adults at the beginning of the study. And as you can see, the take-home message is by 10 years, or at 10 years, because this is prevalence, basically 33%, again, of the borderline patients were obese, versus only 22% of those with other forms of access to psychopathology. So there's something about BPD that leads to a greater amount of weight gain. In terms of male and female, again, we can look at the last set of columns and see that it was 34% of the women versus 27% of the men. Not that much of a difference, but many other studies have shown over time that men tend to actually gain more weight than women. So exactly what this is about, we're not sure. Now, in terms of, this is probably the most important slide in this group. You can see that non-recovered borderline patients are more likely at 10-year follow-up to be obese than recovered borderline patients. And these are people who recovered sometime over this first 10 years of follow-up. And you can see that for recovered borderline patients, the increase in obesity went from 10% to 15% to 21% to 21%. And for the non-recovered, it started higher, twice as high, 22, went to 44, stayed at 44, and then went up to 47. And this obviously is very concerning, and all these things are tied together, and which came first and which followed the other one is hard to know in a naturalistic study, and I think it would be hard to know in a controlled study as well, because you wouldn't have all these moving parts in a controlled study. Now, context for obesity prevalence. This Center for Disease Control figures indicate that 16% of Massachusetts residents during this period of time were obese. Massachusetts is the second thinnest state in the union, following Oregon. Thus, our BPD patients who mostly continued to live in Massachusetts were twice as likely to be obese as other residents of Massachusetts. And non-recovered BPD patients were 3 times as likely to be obese. So this is a problem. And in my years as not only a researcher at McLean, but as a clinician and supervisor, I've had a really hard time getting trainees to pay attention to this. I've had surprisingly less difficulty getting colleagues to pay attention to this. And oftentimes, like I treated a woman who was a very successful nurse who had a bad course of her BPD and gained a lot of weight. And the resident who was treating her at that moment explained to me who she was, and I said, yes, I know her. And, she used to be blah, blah. And he said, she was always like this. And I said, well, no, I've known her for a long time. He would not believe me that she used to be slim and high functioning until he went into the tunnels and got her medical record. We still had paper charts at that time, and looked at them together, and he was stunned, maybe because of his youth, that people actually can be one thing at one time in their life and something else at another time. But it was an eye-opener for both of us in very intriguing ways. Now, let's look at how stable is obesity in this population. Judging people's obesity from baseline. In this study, obesity at baseline, or weight and height, were measured as part of the admission procedure to McLean. We have used self-report weight and height reports at the follow-up periods. But as you can see, and this is a comparison of borderline patients versus OPD patients, that borderlines basically are less likely to remit in terms of their obesity than those with OPD. In fact, about a third remit, 35%, whereas the other group, from baseline obesity, it's 57%. So remissions, not that common. One thing we haven't had time to analyze is that as we've gone along, quite a few patients have had bariatric surgery. And this was after struggles with losing weight, and exactly what percentage of these people had bariatric surgery as opposed to lost the weight in more traditional ways, I'm not sure. Time to recurrence, as you can see, borderline patients, 70% by 4 years after remission have a recurrence of their obesity. Again, that's a body mass index of 30 or greater, and that's only a third of those with other forms of access to psychopathology that looked remarkably similar to borderline patients during their index admission. In general, let me say that they've done much better overall. Their ability to work is a remarkable difference from the borderline patients. And time to new onsets, also unfortunate news in terms of this topic, which is that of the non-obese people, by 10-year follow-up with the borderlines, 32% were now obese, and 23% of those with other forms of personality disorders. So there's weight gain across the board. And how much of this weight gain is also due to gaining weight during pregnancy and not being able to lose it is something we have to look at. Now, the course of obesity in BPD and OPD patients, borderline patients, as we've seen, are less likely to have a remission of their obesity. They're more likely to have a recurrence, and they're more likely to have a new onset. So this is a particularly important area that you as thought leaders really need to bring to your hospitals, your clinics, your private practice, to really make it plain it doesn't have to be this way, and what can you do to stop it and change it. And I always feel that as social workers and psychologists, we have a real responsibility to monitor not only our patients' weight and other health issues, but also to monitor what medications they're taking and to make firm recommendations if things are really out of control. And not just to say, oh, the doctor is taking care of that. The doctor is often your brother, your cousin. You can speak to him or her, and you can collaborate on the fact that how much of these medications treating well-known and understood Axis I disorders, how much were they a desperate attempt to help a patient who people were afraid would kill herself, and how much are they now leading to a destructive downward spiral in health? And it really seems to me that we have to take responsibility for this. We can't control what another treater does, but we can understand one of the reasons borderline patients continue with these medication regimes is they don't want to lose the relationship with their psychiatrist or their PCP. They're very affiliated people. That's a strength, but it can also be a weakness. And that you can encourage the person to see that not all relationships last forever, or they could cut the medications down from 5 to 4 to 3 to 2 to 1. But it's a work in progress, but it's not something we can just blow off as not our thing. If you're the person's primary treater, everything is your responsibility. Now, obesity-related illnesses and BPD, not surprisingly, obesity and BPD is related to the exact same illnesses that obesity is related to in everyone else, but in a documented, statistically significant way, these young patients, still in their 30s, who are obese have elevated rates of osteoarthritis, diabetes, hypertension, chronic back pain, urinary incontinence, which is particularly embarrassing and upsetting, GERD, and gallstones. So people who are in their early 30s at this time point, on average, have a medical picture that actually looks more like they're in their 60s or older. And this is really concerning. And we've had the sad experience. We interview people every 2 years. And one case in particular sticks in my mind. This was an obese woman who could no longer travel to McLean, so the rater went out to her home, and she said, well, thank you very much, and as you know, it'll be another rater next time, but we're looking forward to your participation. And the woman said, well, I was turned down, as you know, for bariatric surgery. I don't think I'm going to be here next time. And 2 years later, when her time for interview came up, her mother wrote me a letter and said that, in fact, she had died of obesity-related causes. This is not a minor matter. This really rivals suicide as something that will really take the life from a patient. Now, definition of CBMI, what is this concept? We calculated this concept by averaging the values of BMI from baseline to that of each of the relevant follow-up periods. For example, and this is cumulative CBMI, or cumulative BMI, at 8-year was calculated by adding baseline 6-year and 8-year values of BMI and dividing by 3. And we did this because we wanted a running or rolling measure of the effect of obesity, or weight gain actually. Now, over 10 years of prospective follow-up, increases in cumulative BMI were increasingly associated, or were significantly associated with self-mutilation and dissociation, but not suicide attempts. Those gaining the most weight had significantly greater risk of engaging in self-mutilation and dissociation, or having that as a symptom, but not suicide attempts. Here, in terms of functional outcomes, and this is perhaps the saddest, one of the saddest areas, increases in cumulative BMI were also significantly associated with having no life partner, a poor work or school history, being on disability, being rated with a GAF score in the fair or poor range, and having a low income. And one of the cases that sticks out for me clinically was the case of a woman who was very intelligent, worked at a law firm, did well, but was asked to work in the back room because the senior partners didn't want their clients to see an obese person working in their fancy law firm. And so she had less chance for advancement, and she knew that she was not advancing the way she could, but she was having a really hard time losing. Medication-related weight is hard to lose. In addition, increases in BMI were related to having 2 or more obesity-related medical conditions and using costly forms of health care, and that for us would be emergency room visits and medical hospitalizations. And basically, increases in cumulative BMI may be a marker for adverse symptomatic, functional, and medical outcomes in patients with BPD. So it's not just comorbidity with axis 1 disorders, it's actually medical comorbidity that's very important. Now, after 16 years of prospective follow-up, 4.5% of borderline patients have committed suicide. So only one additional patient has actually committed suicide in the last 6 years. But 4.5%, exactly the same percent, have died of other causes, many of which were obesity-related. And this, I think, is a wake-up call to all of us. Now, the significant predictors of obesity that we found at 6-year follow-up were family history of obesity, lack of regular exercise, chronic PTSD, perhaps suggesting a lot of childhood adversity and adult adversity as well, and aggressive pharmacy, which, as we've talked about, was 3 or more concurrent standing medications typically an SSRI or atypical antidepressant, a mood stabilizer, typically not lithium, and an atypical antipsychotic. Now, work done by Heather, a student that Heather and I shared, Jolie Weingeroff, in preparation, has found a slightly different set of significant predictors of obesity over time. These are time-varying predictors where they can be. Family history of obesity, again, atypical antipsychotic medication as opposed to aggressive polypharmacy, and binge eating disorder. And interestingly, there is no interaction between antipsychotic medication and binge eating disorder. Now, polypharmacy and borderline personality disorder, there is no empirical evidence for its efficacy. And there's only been one randomized trial, and it was by our group, that has assessed its efficacy, finding that monotherapy is as effective as polypharmacy. And we studied olanzapine versus fluoxetine versus OFC. This is the only factual data on this topic in this patient population, and basically showed one medication works as well as two. There is no magic bullet for medicating borderline patients. You could give them every single medication in the cupboard, and all you would do would be costing a fortune and leading to weight gain and demoralization. A lot of these side effects and symptoms, like urinary incontinence, just are mortifying and really take away people's social chances. Atypical antipsychotics, as we all know, are associated with high rates of obesity in a number of diagnostic groups, particularly people with schizophrenia and bipolar I disorder, and very high rates of the metabolic syndrome, which we will be following, and that's abdominal obesity, high blood pressure, insulin resistance or glucose intolerance, and blood fat disorders, high triglycerides, low HDL cholesterol, and high LDL cholesterol, each of which foster plaque buildup in artery walls. This is a known syndrome associated with these medications, which can be life-saving for people with chronic psychotic disorders. But whether they're important for borderline patients is another matter. Now, our main findings were that obesity is common among borderline patients at any time point, but increasing prevalence over time, particularly those who have not recovered from BPD. So it's a marker of poor functioning. Obesity is not a particularly stable condition in those with BPD. Remissions, recurrences, and new onsets are common. Obesity negatively impacts physical health of borderline patients. As I reported before, they're evidencing conditions common in older adults while still in their 30s. Main findings also, family history of obesity is a consistent predictor. Pharmacotherapy is also a consistent predictor, either aggressive polypharmacy or atypical antipsychotics. Other predictors are lack of regular exercise, chronic PTSD, and binge eating disorder. These are also implicated. The clinical context, as I mentioned, we now have 5 forms of comprehensive treatment for BPD, psychosocial treatments, and none of these treatments focus on the psychosocial functioning of those with BPD, and none focus on health issues either. And I challenge all of you who are therapy developers and implementers to really think about adding some of these things around work and health to your treatments and not be looking to, I'm going to send this person to a vocational counselor, I'm going to send this one to a nutritionist. A lot of the patients can't afford all these multi-modalities, and they sort of get lost, and I think that is one of the points Carlos was making, that you can have 10 different people treating these patients, and does it make more sense to have 1 or 2? And clinical implications, as I mentioned, mental health professionals need to focus their attention on obesity and obesity-related illnesses in borderline patients where necessary. And obese patients with BPD may need a BPD-sensitive weight loss program involving both exercise and nutritional counseling and continued interest and involvement by their primary treater. I don't think anything will happen about weight loss unless you leverage your therapeutic alliance with the patient to take on what can be a frightening thing, because as I have a borderline patient who's quite heavy, and her main reason for not, and it was medication-induced, is that she's afraid of becoming too sexually attractive to men. She's had a very bad history of trauma, and she knows when she was very slim, she was very popular at McLean with a lot of male patients, some of whose attention she welcomed and many of whose attention she didn't, but she's really afraid of stirring up all of her trauma issues. So it's a more complicated thing than just losing weight. Another set of clinical implications, they may also need an advocate, as we've talked about, concerning the medications that are being prescribed, particularly as rates of psychotic-like symptoms are relatively low in borderline patients as time progresses, and they're also relatively low to begin with. So why someone's on an atypical antipsychotic, they're not treating psychosis or even dissociation in borderline patients. What they're treating is anxiety. And it's not really what they were meant for. And ultimately, it's difficult to know if using these medications is life-saving, shortening, or both at different times or for different patients. And in conclusion, let me say that taken together, the results of this study suggest that a substantial minority of borderline patients, despite strong symptomatic progress, struggle with obesity and obesity-related illnesses. And what's sad is that so many of these patients, these are illnesses related so strongly to treatment. Our job is to help people in all ways and not to overlook that they only have one mind, they also only have one body. Thank you very much.
Thank you, Dr. Zanarini.
You're welcome.
We now have time for questions. I have a first question that's already come in, and I'll read it. As a new clinician, I assess patients for BPD and have the most trouble with understanding the stress-related paranoid ideation or disturbed cognition. Could you give some concrete examples of this criterion?
Sure. It's a funny item. It's an item that John Gunderson wrestled into DSM-4 in some ways because of the work we had done at McLean on this topic. Borderline patients often suffer from chronic suspiciousness and distrust. A lot of this can be seen as a response to childhood adversity, not just some symptom relating them to schizophrenia, which used to be a belief that was common. When they're stressed, it can get worse. It rarely goes into the realm of actual psychosis. And in terms of dissociation, what they're really talking about are derealization and depersonalization, feeling like you're unreal or that things around you are unreal. These are not symptoms of psychosis, they're symptoms of troubled thinking. They also don't yield very much to medication. They yield, in my experience, much more to support by a therapist and some reality testing. But often patients just don't realize how unusual their thinking is. I remember a very practical therapist, someone who's now long retired, treated a young woman who thought she was communicating with God. And being a practical person, and also an analyst, a strange combination, she did not actually rush to medicate her patient. She simply said, "Could that be your own thoughts?" And the woman thought about it and said, "Well, yes, I guess those are my own thoughts." So she avoided medicating the patient aggressively by simply exploring with her, could it, because this is a very socially isolated woman who's actually gone on to have a major career. So that's something to think about. I hope I answered your question.
Question is whether parenting, being stay-at-home parent, was considered in the vocational functioning in your categories.
Mothers or fathers who stayed home and took care of their children full-time were counted as having full-time work.
What percentage of your patients in the study suffer from binge eating disorder? How much of weight gain can be accounted for by that, by binge eating?
I don't have these statistics. It wasn't that high. It was noticeable. And we really can't tell what percentage. Obviously, it's a significant contributor, but it's not the only factor. And by the way, binge eating disorder is a complicated concept. We think of people eating enormous amounts of food in brief periods of time. I would say that something we didn't particularly study, chronic snacking, what I call chronic snacking disorder. might be more of a problem in this group because they not only, everything came down together on these people in the sense that they often weren't that active, they were despondent, that they weren't moving ahead, they spent a lot of time alone, and so they were eating relatively consistent but not particularly large amounts of food throughout the day and the evening. And I think that's a problem to pay attention to, too. It always amazes me how you can have someone who's gained 100 pounds, 200 pounds. I mean, we've got people in the study who are 5 feet tall and weigh 530 pounds. This is an enormous weight gain. And nobody mentions it in therapy. Instead, they're talking about the transference. It's like, who cares about that? You have somebody who's constantly going to the hospital for various ailments, and it's like, hello, do you notice anything about this patient that's changed over the years? And it is amazing what people can deny, and it's not just the patients in denial.
What is your experience with 12-step programs such as OA? There's also ABA listed as a support for BPD plus eating disorders. I think all these programs are useful. I think surprisingly, Weight Watchers is very useful. Weight Watchers, I should say, with the force of your relationship to the patient behind it, that you recommend it, you believe in it, and you believe in the patient's ability to lose weight. And it is so hard because a lot of these patients are trying to lose weight while they're taking the very medications that created the problem. And they're often afraid to give them up because the doctor has told them it's essential for their well-being. So that is really a problematic situation. And I always encourage patients to do some kind of low-impact exercising, even walking an hour a day. You might say, who has an hour a day? Some of the patients who are obese have the time. Really will contribute a lot to elevating their mood as well. There's a question of, it's in my work with borderline patients, I have not observed the effectiveness of psychiatric meds. Would you speak to this?
I'm not sure what the question was.
I think it's basically whether a referral for medication would be indicated in a patient with borderline personality disorder who's not on medication. At what point would you recommend?
Sure.
I think that's the question.
All psychiatric medications that have been tested work about equally well with borderline patients and on the same symptoms, which is intriguing. And they work modestly. There is no medication for BPD. There is no combination for BPD. There are medications that can be used to treat the co-occurring disorders, but oftentimes psychiatrists see co-occurring disorders that don't exist, and my personal not favorite is bipolar disorder. I would say 90% of our patients have been told they're bipolar 1 or 2, although interestingly enough, they've never been hypomanic or manic. So you sort of wonder, how can that be? And so for some reason, psychiatrists believe bipolar disorder has a better prognosis than BPD. It doesn't. And it's a more treatable condition than BPD, and it's not. And that's something else you have to take responsibility for. If a psychiatrist, presumably who you know and are working with and even refer to, insists your patient has a disorder you know they don't, perhaps talking to that person or even suggesting a change of psychiatrist or psychopharmacologist would be a good idea. But meds can help people with co-occurring disorders, but these patients tend to be seen as having 4, 5, 6 co-occurring disorders, many of which are simply an amalgam of BPD symptoms that are being, in some ways, misconstrued as an Axis I disorder.
One question was specifically about what you just mentioned, differentiating borderline from bipolar disorder. Can you speak just a little bit more about making that differential?
Sure. I think a lot of psychiatrists, for some reason, see borderline lability as some kind of special bipolar II disorder. And patients are also then told they're rapid cyclers. Now, there are definitions in the DSM for these things. Having 5 to 10 mood changes a day is not rapid cycling. It's BPD, and there's nothing wrong with BPD. It's a disorder with a dignity all of its own. But it does not help the patients or you as treaters to mislabel things. We conducted a basically a psychotherapy trial of psychoeducation with very young borderline women, 18 to 19. And the treatment worked quite well. But the most important thing was I had to tell all 50 women they had BPD. And none of them really minded. In fact, one of them said to me, "Oh, Dr. Zanarini, don't be so sad. Borderline, schmorderline, it's all the rage." The point is, we have our own hang-ups as clinicians. The patients are eager to find out what's truly wrong with them, just as we would be if we had an illness. And they're happy to know that they're not alone. So many of the young women said to me, "I'm ill. I thought I was just bad or evil, or I was the only one." And they were really relieved to hear that they had an illness about which something was known and there were treatments that were available.
We're going to take a question from the balcony.
Yes.
From David Klemanski.
Are there any situations where you would expect your patients to say no to medications?
Are there
Any situations where you'd expect your patients just to absolutely say no to any medications that might be offered or prescribed?
Sometimes patients say no, but surprisingly, it's infrequent. People tend to be compliant with doctors, and if somebody tells you this medication will help, once you're taking it, and then you're taking 2, 3, 4, how do you know which one works, or how do you know if any of them work, actually, and it isn't therapy or maturation or something else?
There's a point being made that not all atypical antipsychotics increase weight, that Geodon and Abilify have not been associated with gain. Topamax associated with decrease in weight. Would you agree with these things? Any comments on this?
Sure. I think some medications are less likely to cause weight gain among the atypicals than others. Obviously, clozapine and olanzapine cause the greatest weight gain. But even among SSRIs, some cause more weight gain than others. And Topamax is associated with weight loss, but it's also known as Dopamax for a good reason. It does impair people's cognitive functioning. And again, you have to say lose 10 pounds or lose 10 IQ points, which is better for your future.
We have a question. What would be the most important to target or focus on the treatment of an early adolescent with an emerging borderline personality disorder? What is the most important early intervention and or prevention of adult BPD?
It's a good question. At McLean, in conjunction with Mount Sinai and Dr. Marianne Goodman, we've started a study of the course of adolescents with BPD, 13 to 17-year-olds. And these are people who are disturbed enough that they're hospitalized. These are girls and boys who've really run through a lot of treatments, and then finally their parents find out that maybe they have BPD and things seem to get better. This is such a new field that it's hard to know. DBT seems to work for these adolescents. The other forms of treatment I don't think have been tried, like mentalization or transference focus. And in terms of prevention, we're really not there yet. I could speculate, but we first have to document, as we're starting to do, that this disorder does occur in adolescents before we can even conceptualize how to prevent it.
Have there been any new studies utilizing cutting-edge nutrition like oxygen and chlorophyll-based superfoods to alleviate BPD symptoms and consecutively allow for weight loss as well as increase in energy and mood? I'm not familiar with this.
Interesting question. I am not familiar with these techniques, but I don't think there have been studies. I have not come across them in literature reviews.
Okay. And there's a comment about the general prevalence of obesity versus the impact on socioeconomics, and the person writes, it's generally known that the socioeconomic status has an indirect correlation to BMI. I think the point might relate to direction of is obesity causing socioeconomic status, or just, is there more you could say about this, about just the relationship between SES and obesity? I think you've spoken about it some.
Right.
So,
well, SES is a moving target, just as is obesity. People's social class can go down, stay the same, or get better over time. And we have plenty of patients in this study who are obese, who are college graduates, who came from middle class or upper middle class families, and plenty of people who came from working class backgrounds who are normal weight. So I really think it is bidirectional. But what's striking to me is how much still we're contributing as treaters to this problem. As we try to help these people, sometimes they're inadvertently being harmed.
We have someone commenting on the discussion of borderline versus bipolar and the point of whether this facilitates third-party payers who would cover an Axis 1 condition, the fact that bipolar is focused on as a biologically based mental illness, and is there much research to support borderline as a biologically based mental illness? And just to comment on that.
The answer is not so much. Basically, BPD is it's an obvious illness, but it's a more subtle illness biologically than schizophrenia or bipolar 1 disorder. The kinds of research that have been done are not particularly consistent or convincing. But basically, in terms of insurance, the issue is to get third-party payers to pay for the treatment of BPD, which they're starting to do. It's not to go around it. It's a very different thing to say to your patient, I'm putting down major depression on this insurance form, which you also have, but your real problem is BPD, or to say to someone, BPD, you don't have that. You have bipolar disorder, and that's what I'm putting on this form. You're actually telling people that they have something they don't have, which I don't think is done maliciously. It's done, people are convinced that that is the problem. But unfortunately, if you never have hypomanic or manic episodes, you have no known sleep disturbance that's associated with having bipolar disorder. How you can meet the criteria still escapes me.
Final question from here is discussing BPD as a risk factor for bariatric surgery. Can you comment on your support or lack thereof for bariatric surgery for obese BPD patients?
Sure. The young woman I mentioned who was denied access because she was on a lot of psychiatric meds and she couldn't or wouldn't go off of them. I think the logical thing is to turn to the expertise of the people running these programs. They usually insist that you lose a certain amount of weight to show that you're going to be able to not engage in overeating after the fact. You might want to have a med adjustment. You might want to try exercise, nutritional counseling. But if you've tried all these things and you haven't been able to lose what really is a massive amount of weight, we're not talking about a few pounds over the line, we're talking about many, then sure, I think you should go ahead with it. You want to save your life. You want to have a better life. You want to have a chance of a full social life. Also, if you're very overweight, it's hard to work. I would support it as a last-ditch intervention.
Thank you. Thank you, Dr. Zanarini.
Thank you.
We will now have a 15-minute break. We'll be beginning again promptly at 11 o'clock. Please, if you have not been turning your cell phones off during the conference, please be sure to turn off your cell phones following the break. Thank you very much.